Hi, thank you very much. Can you hear me okay?
Yes,
Okay.
it's good to see you. Thank you. I'll hand over to you, Kiran.
Yes, great. Um, okay, are you able to see my slides?
Yes.
Okay, I'm just gonna open it like this because I have two screens here. Well, thank you very much, Claire and Lindsay, for inviting me to speak. It's always a pleasure to speak to patients, providers directly, even though it's by Zoom. So I'm going to be talking today about looking beyond the clinical symptoms of core narcolepsy symptoms. And here are my disclosures. I have some research support from Jazz Pharmaceuticals, and I'm a consultant to Harmony Bioscience and Alkermes. Okay, so I'll jump right into it. So I guess the first thing I wanted to talk about, even though today's talk is really about the other symptoms beyond just the core symptoms of narcolepsy, I think it's just worth kind of mentioning that the frequency of the classic, quote unquote, classic symptoms of narcolepsy is highly variable. Daytime sleepiness is a problem, of course, that affects almost all patients with narcolepsy. It's a defining feature. But these other symptoms like cataplexy, disrupted nighttime sleep, sleep paralysis, and hypnagogic hypnopompic hallucinations are really more variable. And when we take them all together, this classic pentad is only reported in up to 25% of patients. So sometimes from a diagnostic standpoint, when we're kind of trying to make a checklist of diagnosing narcolepsy, we can be misled when not all the symptoms are there, but the symptoms are variable. So that explains why sometimes narcolepsy can be a real diagnostic challenge. I think to Dr. Davidson and Dr. Scammell's points, assessing the core symptoms in a broader way, in a more meaningful way, is important in a clinical setting. So we're working on a patient-reported outcome scale that tries to incorporate not just, how sleepy are you, but, how is it affecting your social life? How is it affecting your academic work? How is it affecting your work? Basically that does help us assess sort of the severity of the symptoms. I'm just getting a message here. Are you able to see the slides too now?
Yes, we are. Thank you.
Okay.
Yes, perfect.
Same thing with the cataplexy. So, we oftentimes will ask about the frequency of cataplexy, but cataplexy comes in two flavors. It can be partial or it can be full. And what's probably most meaningful is the impact on the patient. Are they suppressing emotions because they don't want cataplexy to emerge? Are they embarrassed? Or are they avoiding social relationships or going out because of it? These are really important decision factors for whether we initiate treatment for cataplexy or not. And so that qualitative discussion, meaning like a little bit more discussion about how it affects patients, is really important. Disrupted nighttime sleep, that's not always a very clear term to patients. When we're asking it, we're generally asking about how many times are you waking during the night? Are you having a hard time staying asleep? But other things happen during the night, such as sleep talking, sleep shouting, acting out dreams, lots of twitching during the night. So that might mean different things to patients when we use the term disrupted nighttime sleep. And then sleep paralysis and sleep-related hallucinations, we oftentimes ask at the time we're trying to make a diagnosis of narcolepsy. But for some patients, this can be a really bothersome symptom. It can be annoying at the least, but for some it can be actually scary. And I've had patients try to avoid sleep because they really, are so bothered by the symptoms. So while the core symptoms are not the focus today, I think it's certainly important to go into more detail or share more detail about the symptoms and impact with healthcare providers. And if there are healthcare providers on the call today, these are some of the validated outcome tools that are currently available to help assess daytime sleepiness. The Epworth comes in an adult and pediatric form. Sleep disturbance can be measured by various scales through PROMIS. And there is a global narcolepsy severity scale that's really aimed at narcolepsy type 1. And again, we're in development and validating patient-reported outcomes. This was a study that we had done with Wake Up Narcolepsy. This was a consortium of patient advocacy groups that was trying to collect data for the FDA several years ago, and we had the privilege of doing a secondary analysis of the survey data through Wake Up Narcolepsy. And one of the questions in this survey, many people on the call might have actually answered some of these questions, was what are the most important or impactful symptoms to you on a day-to-day basis? And I found the results really interesting because, again, we sort of as physicians are so focused on the core symptoms of narcolepsy that help us diagnose the symptoms like sleep paralysis or hypnagogic hallucinations. But patients were really telling us that other things are more important to them on a day-to-day basis. In narcolepsy type 1 and narcolepsy type 2, of course, daytime sleepiness are the most burdensome or impactful symptoms. But second was cognitive difficulties that actually came above cataplexy in narcolepsy type 1, general fatigue, which, I thought this was a really important point, that patients are able to recognize the difference between sleepiness and fatigue or feeling tired and rank them differently. And then disrupted nighttime sleep was their fifth most impactful symptoms. In narcolepsy type 2, daytime sleepiness again was the top symptom, but all the other symptoms were more general. They weren't related to sleep paralysis or hallucinations or any other specific feature of narcolepsy. They were related to fatigue, the cognitive difficulties, feeling unrefreshed when they woke up, and mood problems. And so I think, again, when we're thinking about patient-reported outcomes, these are the kind of measures that we want to start thinking about when we're assessing how a patient's doing. Okay, so moving on to medical comorbidities of narcolepsy, there's many. And in this talk, I'm going to be focused on a handful. But they really range, and I've taken the top most frequent ones that have been reported, obesity being the most common. Typically, obesity occurs within a few weeks to months right after symptom onset. And we really don't know the mechanism of why that occurs. But obesity is really a chronic problem among patients with narcolepsy, and the frequency among patients is 25 to 60%. In younger children less than age 10, precocious puberty has been reported in up to 40% of patients. Again, a reason to bring any concerns up to a healthcare provider. Obstructive sleep apnea can occur in up to 25% of patients. And this is really important to know because sometimes this leads physicians or healthcare providers down the wrong path. If they see it on an overnight sleep study, it takes them away from a diagnosis of narcolepsy potentially, but they can have comorbid obstructive sleep apnea, meaning narcolepsy and obstructive sleep apnea. And this might be related to the obesity, but patients, in my experience, do benefit from treatment of their obstructive sleep apnea in terms of improving their sleep quality and their daytime sleepiness. Hypertension I'll go into a little bit in more detail as it's really becoming a more emerging comorbidity that is helping us kind of manage patients and how to avoid long-term effects. Autonomic nervous system problems is a very large category, and I'll go into what those include because the symptoms are very broad, ranging from night sweats to headaches to fainting episodes to heart racing episodes. Another frequent comorbidity is general GI symptoms, and this might be dysmotility or constipation, headaches or migraine headaches, and endocrinopathies, including thyroid issues. So there's a whole range of other health problems beyond just the narcolepsy symptoms that healthcare providers should be managing or at least referring to other subspecialists as needed. But I think important for a patient population to know. So focusing a little bit more on some of these comorbidities, obesity, again, is a common issue. And it's really not clear what drives the obesity problem in narcolepsy. Orexin, we know, has widespread projections in the brain to various areas that help regulate energy homeostasis and feeding behaviors. But orexin actually is important for motivation and purposeful feeding. So one would think that if in the setting of orexin loss as in narcolepsy, that states of like anorexia or hypophagia, not eating so much, would be problems. And certainly I have a large clinical population of very lean patients. I don't have anyone I would say is anorexic, but very thin. But obesity, on the other hand, is a separate issue. So it's not clear why we see these sort of differences within patient groups. In clinical research, the mechanism that underlies obesity really has not been clear. In mouse models of narcolepsy, there's been some data suggesting that there's abnormalities of something called brown adipose tissue. And brown adipose tissue is your good fat, if you will. It's kind of the metabolically active fat, helps you burn calories. So one thought was maybe patients with narcolepsy have less of that, but there have been 2 clinical studies showing that they actually have the same amount as healthy controls. It doesn't seem like there's conclusive results about basal metabolic rates, meaning how much energy you burn at rest. There was one early study showing that patients with narcolepsy do have lower levels of this basal metabolic rate, but 2 subsequent studies did not show that. And one study showed that patients with narcolepsy have the same amount of energy expenditure. So how much energy you're burning when you're doing physical activity or any of your sort of normal things like moving around or eating or digesting is actually the same between narcolepsy patients and control. So really still a mystery. One interesting study that that caught my eye a few years ago is this study where they looked at the behaviors of eating of patients with narcolepsy compared to healthy controls. So I'm paraphrasing this study, but basically they had patients with narcolepsy and healthy controls, and they gave them food that they like. So these tended to be salty and sweet foods. And they let them eat kind of, whenever they wanted. They let them have them as much as they wanted. They considered these valued snacks. And then they did a study where the controls and the patients with narcolepsy were allowed to press a button for whenever they wanted one of those snacks. And so the controls pushed the button less once they were full of those snacks. So they were satiated, they didn't push the button so much for them. But the narcolepsy patients continued to push the button for those snacks even though they had already had them. And then another aspect that I thought was interesting in this study is they actually put food bowls during this entire study that allowed people to snack at lib whenever they wanted. And they just simply observed how much patients with narcolepsy ate compared to those healthy controls. And they found that the narcolepsy patients ate 4 times more than the healthy controls. So this is a interesting sort of suggestion that maybe the problem with the obesity is just the behaviors, that patients with narcolepsy are not recognizing the satiety that they have, and they're not making good food choices because they're really not, they're just kind of eating mindlessly or not aware of how much they're taking in. I think that's important to know because from a behavioral standpoint, things like food journals or food diaries actually could be very helpful for obesity mitigation. Hypertension. So as I mentioned, this is becoming a more scrutinized issue, I think, among the medical community because we use medications that increase blood pressure to treat patients with narcolepsy. So a few years ago, there was a study called the BOND study. This was looking at comorbidities among patients with narcolepsy, and among them, they looked at hypertension. This was claims data, meaning billing code data of almost 9,300 patients with a billing code of narcolepsy compared to 46,000 other types of patients. And what they found in this study is that 44% of the patients with narcolepsy had a billing code for hypertension versus 31% of the controls they were looking at. And a different study, basically based off self-report, they would call patients and ask them about comorbidities. Patients with narcolepsy had higher reporting of heart disease, nearly double then of controls. So again, we're not really sure what causes the hypertension in narcolepsy. but medications probably have something to do with it. I'll show you some data suggesting that stimulants, traditional stimulants like methylphenidate or amphetamines, and SNRI medications that are used for cataplexy like venlafaxine might have something to do with that. It's certainly possible that obesity has a contribution to hypertension, but interestingly, there may be intrinsic causes of hypertension in narcolepsy, meaning that a state of orexin deficiency may alter the tone of the blood vessels in some way. So this was the study I had mentioned before. This was a study done by the Dovier group in France, where they took patients with narcolepsy compared to healthy controls, and the patients with narcolepsy either were treated with stimulant medications or modafinil, or were untreated. And what they basically saw, this is the systolic blood pressure here that I'm pointing to, is that the patients with narcolepsy had hypertension at a rate of 41%, even if they weren't treated with any medication. So these were drug naive patients. And 58% of patients had hypertension even when they were on drugs. So the frequency actually was pretty high in both groups. And the elevations in blood pressure were seen across the 24-hour period. What they also showed was that the blood pressure of patients with narcolepsy in normal sleep, actually I should just start with this, in normal sleep we all have lower blood pressure, that's considered normal. But patients with narcolepsy tended to have a failure of that dipping. Their blood pressure stayed high or stayed at the same wake level across a period of sleep. So we call that a failure of non-dipping. And that seemed to be present in both patients who are on medications and patients who were not on medications. And so basically the time period of where that elevated blood pressure was tended to be more pronounced during sleep. And what they also found was that the relationship of this higher blood pressure across sleep related to how much REM sleep, rapid eye movement sleep patients had. And this was important because we know REM sleep is this sort of state of synergistic, of sort of sympathetic activity. And so maybe it's a time period they're experiencing that predisposes to higher blood pressure across the night. Autonomic disorders, I realize this is something I hear a lot from patients about, but there's just not a lot of data about it. I would call it a gap in the literature for sure. But problems with autonomic disorders range from anything from pupillary anomalies, like your pupils not adjusting to the darkness or light appropriately, fainting spells, erectile dysfunction, night sweats, GI problems, headaches, and extremities feeling either hot or very cold. These are all under the bucket of autonomic disorders and probably not well studied because people assess these differently, whether it's by survey or by objective studies, you'll get different responses. Cognitive comorbidities, I think it's important to sort of spend a little time on simply because, as I mentioned, this was one of the top concerns identified by narcolepsy patients in that original study we had done. The good news is that IQ is actually normal across many studies done in patients with narcolepsy, meaning that the cognitive scores were normal or if not high. But they did have some problems in the areas of working memory, attention, impulse control, and some studies show lower verbal IQ, so the ability to understand verbal information or comprehend reading segments and whatnot tended to be slightly lower in patients with narcolepsy. And oftentimes when we see lower verbal IQ, we also see problems in working memory. So there could be some additional cognitive issues here. And I think importantly, educational problems, depression, and ADHD scores were all independently associated with poor quality of life of narcolepsy patients, I think really prompting the need for healthcare providers to take these issues very seriously, and maybe we should be doing more formal neuropsychological testing to identify problems in patients with narcolepsy so we can address them in a meaningful way. Attention deficit disorder is a common issue. About 35% of patients in one study, and that was narcolepsy type 1 and type 2, had issues relating to impulse control, hyperactivity, and inattention. This was adults and children. And in this study, I think someone had asked Dr. Scammell in the last talk if these problems are related to the sleepiness. At least in this study, patients who were taking stimulants and modafinil showed improvements in their sleepiness, but they didn't show improvements with their ADHD scores, suggesting that maybe the sleepiness isn't sufficiently alone driving these ADHD symptoms. Certainly it's probably contributing, but it may not be sufficient to simply treat the sleepiness to help the ADHD problems. And then I know we all hear this symptom a lot of brain fog. And brain fog is something we hear across many different sleep disorders, but certainly more common in patients with hypersomnia disorders, where people really just report the slow, effortful thinking, poor mental clarity, difficulty thinking while speaking, hard to get out what I want to say, kind of mental cloudiness. And we really haven't seen many good studies on this. It is something that we're trying to explore further in our assessments of the patient-reported outcomes because we recognize it's such a common and impactful symptom. And then psychiatric comorbidities. So mood disorders, are very common, so 25 to 33%, depression, anxiety, obsessive compulsive disorders, and social phobia. And as Dr. Ryan and Dr. Scammell had mentioned, these problems are probably now worse in the setting of COVID. I think it's important to just note that many of the medications that we use for the treatment of narcolepsy actually have side effects that relate to mood disorders. So this is a very important conversation to have with your healthcare provider. There really have not been comparative studies looking at traditional stimulants versus the newer drugs that have come out for the treatment. But at least based off reporting, the frequency of side effects of depression, anxiety are higher with traditional stimulants compared to these newer medications that have come out in the last year to 10 years. So what do you do with all this information I just gave you? I think in healthcare settings, it's just really important to have a more global approach to managing narcolepsy. So it's not enough to just ask about sort of the core symptoms of narcolepsy, but really address sort of the broader problems that patients are reporting to us and the impact that has not just on social, but also on their work and academic functioning. Specifically for kids under 10 years of age, we should be assessing their pubertal development because precocious puberty is a problem. We should be looking at growth curves closely and making sure that obesity isn't creeping up. And we should be measuring blood pressure, which certainly is a hard thing with virtual visits. But I'm encouraging my patients to invest in a home blood pressure monitoring so it's something that we can actually keep track of. If you do have concerns about ADHD or attention deficit, you can ask your healthcare provider to assess for that. So at least in the pediatric world, there's Vanderbilt or Connor forms that are just basically survey information for a parent and a school provider to get a global sense of the ADHD symptoms. For other behavioral problems, the child behavior checklist is a survey that's pretty easy to use that healthcare providers are familiar with. For screening of depression, there's patient health questionnaires that take only a couple minutes that could be integrated into clinical visits. And if you do have concerns about these symptoms, asking to be referred to a subspecialist or seeking out a multidisciplinary clinic that has these specialists, so endocrinology for obesity or puberty, precocious puberty, psychiatry for mood concerns or a psychologist, GI for dysmotility or constipation that's not resolving. Cardiology, and there is a branch specifically of autonomic specialists within cardiology and neurology that can assess autonomic problems and neurology if there's additional issues with headaches or migraines or other cognitive issues of concern. I think, just basically when we're using these medications for management, you just should be aware of some of the consequences. So making sure, again, that blood pressure is being monitored, that you're not reaching concerns of hypertension at any point when medications are increased or changed. If high blood pressure is an issue, sometimes I have to take patients off of their wake-promoting medications, and we try to promote a nap. Something that could be substituted for a booster dose of stimulant that they had been using. And naps are not a failure really of therapy. It's very much part of treatment. So a scheduled nap that's brief can be very helpful. And again, as we mentioned, if cognitive concerns are present, making sure that those are brought up as a specific issue to discuss with your healthcare provider, because there's interventions we can do. There's individualized education plans or 504 plan accommodations that we can advocate for. In terms of management of the non-pharmacologic aspects, I believe Dr. Owens is next and is going to be talking about this in far more detail. But just in general, use of naps, managing obesity with better food assessments, food logs, increased exercise is certainly important. Avoiding common things like sleep deprivation, watching too much Netflix late at night, all of these things that affect everybody are also going to affect patients with narcolepsy, but the consequences may be more severe in a patient with narcolepsy. We're very lucky to have Dr. Eric Zhao at Children's Hospital, and so cognitive behavior therapy is very helpful for management of many symptoms related to sleepiness, fatigue, and cataplexy. And I find incredible need for patient support groups like Wake Up Narcolepsy, basically so patients recognize they're not alone through this difficult journey, but also I find patients have the best life hacks to kind of help one another out, and I learn equally from them. I believe Dr. Owens is going to be talking about school accommodations, but I just wanted you to have a couple of slides on that of different things that can be incorporated into day-to-day 504 plans. And I would say during this COVID time, if you're remote learning, things like scheduled naps can still be brought into a remote learning. Remote learning is very hard because it's passive learning for the most part. So having more movement breaks or using a fidget device, to help kind of stay awake can be helpful. Having the ability to record a class so that you can go back and review it later, or the notes can be helpful. Extra time for completing work so you can prioritize sleep. And then for testing circumstances, stop the clock breaks or extra time can be helpful. And for college students, early registration so they can get the classes that they want at the times they need to avoid sleep deprivation can be very helpful. So I think in conclusion, we're really trying to move the model of narcolepsy care to more a global assessment of the clinical symptoms and how they actually impact the day-to-day function of patients, rather than just like a symptom list of like, yes, cataplexy, no cataplexy, and whatnot. And assessing the symptom burden is where we really think patient-reported outcomes can be very helpful down the road. But incorporating all these comorbidities in a clinic visit is actually difficult, but it's simple at the same time once you're aware of them. So if your healthcare providers aren't doing it, making sure you're aware and bringing it up is very important, because I think then in the end, there's a great need to individualize the treatment plan with all of these needs. And as Dr. Scammell and Dr. Davidson had mentioned, everybody's situation is different, and we want to come up with a working treatment plan that works for you. Thank you.
Thank you, Dr. Maski. Sorry, there was a bit of a delay there on my end. That was incredibly helpful, and I learned a lot from that. It never occurred to me to buy Matilda a fidget spinner for all her online classes. And you're right to point out that this distance learning, home learning, online learning is a real challenge and ongoing in many places. So let's turn to some questions. We have about 10 minutes before a break. Just before we do that, Dr. Maski, did you want to talk about the pediatric screening tool at all?
Yeah, thank you so much. Yeah, I think, as mentioned, diagnostic delays are a huge clinical problem still in pediatric narcolepsy. Of course, it's also a problem in adult narcolepsy, but we're focused on the pediatric aspect. And so we've developed and we're currently validating a screening tool that can be used by schools, healthcare providers, that could just be on the internet for parents to access. That's basically helping identify narcolepsy symptoms and then triaging patients to appropriate sleep providers or healthcare providers who know something about narcolepsy or idiopathic hypersomnia, so that patients don't have this very circuitous journey of seeing multiple healthcare providers for their symptoms and accruing various diagnoses. So if people are on the call that have children who've been recently diagnosed with narcolepsy, I would say within a year or 2 years, click on the link in the grab bag that is under Children's Hospital Boston survey. And that would be very helpful to help us validate the questionnaire that we've developed. We're also assessing how the effect of nocturnal sleep disruption in patients with narcolepsy affects memory functioning, as well as mood. That's a study that's conducted at Boston Children's Hospital. So if anyone's local and has a child or is a person between 8 and 20 years of age, we're recruiting for that study as well. Thank you, Claire.
Yes, thank you. It's very exciting, that study, isn't it, to think that we might have a screening tool in schools in the foreseeable future that hopefully will assess children with sleep disorders in the same way that autism's picked up. Mm-hmm. So thank you for that. Okay, let's turn to a couple of questions. Kelly C says, is venlafaxine beneficial for having type 1 narcolepsy, and how does it contribute to hypertension?
Yeah, good question. So venlafaxine is a dopamine and norepinephrine reuptake inhibitor. So basically, the norepinephrine component of it is what's probably very helpful for cataplexy management, but it also might increase blood pressure to some degree. So that study I showed you that showed that patients on venlafaxine had slightly higher blood pressure. That's a little hard to separate out from the stimulant effects, because patients are probably on combination medications, but the combination of the venlafaxine with the stimulants did have higher reporting of blood pressure in that adult population.
Thank you. And Kelly then goes on to ask, how can you control naps? I can't take a nap for 15 or 20 minutes. They're always 2+ hours, and I cannot seem to wake in between. Why does this happen?
Yeah, that's a good question. So yeah, it really is dependent on the person. For some people, especially people with narcolepsy type 2, sometimes idiopathic hypersomnia, the naps actually can be very hard because exactly for that reason, they just have a harder time waking up. Sometimes they don't feel as refreshed as, say, someone with narcolepsy type 1. And sometimes people with narcolepsy type 1 have the same problem. So it is a general problem. So if naps are not helpful and they actually make you feel worse, or you're having a hard time waking up from it, sometimes avoiding them is better, because otherwise we get the situation of people sleeping for 2 to 4 hours and then they can't sleep at night. So really an ideal nap is 30 minutes or less, and if you feel refreshed after it, that's when we strongly encourage it as part of the management plan.
Thank you. Okay, it seems to be a fairly urgent question. Vanessa asks, I have a child with mild sleep apnea, but I have narcolepsy and obstructive sleep apnea. Is it prudent to push my neurologist to test further for narcolepsy given similar other symptoms, including excessive daytime tiredness and other symptoms?
That's a great question. Yeah, so basically if sleepiness is severe, so that can be easily assessed with the Epworth Sleepiness Scale that I had shown before. It's freely available on the internet. It's available on all these various patient-reported patient websites. if it's severe, meaning that the level of sleepiness is above, I would say 10, 12, and especially if it's over 15, that's usually something that would not be explained by just mild sleep apnea. And in those situations, I would encourage them to talk with a person knowledgeable about narcolepsy for further assessment.
And Gillian asks, with respect to obesity in patients with narcolepsy, do you think it could be linked with eating, being a way that some patients with narcolepsy try to stay awake or buy some wakefulness time during the day?
Yeah, absolutely. I mean, I think those are the kind of things that we don't have insight into and very well could be playing a big role in obesity. I think probably the way at getting those kind of research is to do what's called qualitative research, where we interview patients with narcolepsy and discuss their eating habits or their reasonings for eating to get at that, because that's really important. It would really help us tailor our treatment recommendations and guidance.
Laura says, how can you treat hypnagogic hallucinations and sleep paralysis if antidepressants are not an option?
Yeah, good question. So there are various ways. I mean, I think one, you want to make sure that sleep deprivation isn't occurring. Like I just mentioned, sometimes we see the situation where there's long daytime naps and then short nighttime sleep. And so there's a relative sleep deprivation there, and in that setting, the frequency of sleep paralysis and hypnagogic hallucinations can sometimes be worse, or if sleep's just generally dysregulated. So that's an important thing. Sometimes we do use SSRIs at night to try to treat those symptoms. Otherwise, I use a medication called trazodone, which is also a REM suppressing medication to help. It hasn't been well studied, but medications like sodium oxybate have been reported to reduce the frequency of sleep paralysis and hypnagogic hallucinations as well.
Okay, here's one that came up at the beginning of your presentation. Please, Dr. Maski, in your experience, have you heard of any patient who does not have slow wave sleep? The symptoms beyond sleepiness, cataplexy, hallucinations, etc. Are the neurological effects, visual, cognitive, perception, hearing, senses, etc.? Please, I need help.
So the question is about patients who don't have slow wave sleep?
Yeah, the beginning was, in your experience, have you heard of any patient who does not have slow wave sleep?
I mean, yeah, so, well, within narcolepsy group, patients have been reported to have problems with slow wave sleep, but really it's more that it's a problem of more waking and more light sleep is sort of dominant and fragmenting the other stages of sleep. Patients who don't have slow wave sleep, I mean, that's something that comes up in the diagnosis of insomnia, where there's actually real deficits in that. And then, sometimes they benefit from medications or interventions that boost the slow wave sleep.
Thank you. I think we've got time for one or two more. It's just jumped. Sorry, I'm just trying to find it. It was, okay, so, okay. Are there any studies or surveys that show how symptoms compare or relate to medications taken? For example, those taking strong stimulants experience different symptoms and issues.
There really aren't. I mean, I think unfortunately, health insurance or payers kind of dictate the navigation flow of which medication comes first, at least in our state in Massachusetts. Traditional stimulants are usually required first by insurance providers, and if there's failure, then you can go on to another group. So unfortunately, we don't have like good assessment ways, just because there's just like a protocol that everybody has to go through.
Okay, and the last one here is from Vanessa. Is there any correlation between hyperglycemia and narcolepsy?
Good question. I think there is some mouse data that suggests that there could be some metabolic effects of orexin deficiency. Um, type 2 diabetes or type 1 diabetes doesn't come up as a frequent comorbidity. That's why I didn't list it, but it has been reported as a comorbidity in patients. When you look at these large population studies, it's just not as frequent as the ones that I went over. But it basically has to be teased out from obesity, which also increases insulin resistance.